93% of Americans believe that Medicare should cover care at home, and most of them think it already does. But unfortunately it doesn't, it never has, and that gap was written into the law on purpose in 1965 by the people who knew exactly what they were leaving out. This month, a new bill in Congress would finally change that. Medicare would provide 20 hours a week of caregiving help at home with things like bathing, dressing, and eating, all paid for by Medicare. But there's a catch in how it might be funded, and that catch is the same one that got a congressman chased across a parking lot in Chicago in 1989. And before any of that matters, there's a court settlement from 2013 that already entitles you to care that Medicare is probably denying you right now. Here's what I'll tell you in this video. You'll know exactly what Medicare covers for care at home in 2026 and what it doesn't. You'll know exactly what this new bill says, not just the hype and the headlines, but the actual details. And you'll know who pays for it and why serious people on both sides of the political aisle are worried. And you'll know one specific sentence that you can say on the phone that has won thousands of families the care coverage that they were told they couldn't have. If you know someone out there that's caregiving for an aging parent or a spouse right now, please send them this video. I think it could genuinely help them. I'm Neil K. Shah, a Johns Hopkins and NIH-funded caregiving researcher and the CEO of Caregiving. I've helped thousands of families navigate aging, dementia, and serious illness. I'm not a clinician, but a leading researcher and innovator in caregiving, and I've spent years watching families find this out at the worst possible moment, usually in a hospital hallway at 4 o'clock in the afternoon when a discharge planner says the words custodial care, and they suddenly realize that Medicare doesn't cover $1 of it. So let's jump right into it. Medicare does cover care at home, but it confuses everybody. What it covers is only skilled care, like a nurse, a physical therapist, a speech therapist. The trap is the home health aide, the person who actually helps your loved one with things like bathing and dressing, is only covered as a helper. You can only get the aide if you also need the nurse or the physical therapist. There are two more locks on this door. You have to be homebound, meaning leaving home takes considerable and taxing effort, and the care has to be part-time or intermittent. So what does this actually mean for people? Imagine if your father has a stroke. Medicare sends a physical therapist, and aide comes 3 mornings a week to help him bathe. 8 weeks in, the therapist writes that he's plateaued and not recovering more, or getting worse. The therapy ends. And the caregiving aide, the only person actually helping him, stay clean and safe, disappears with it. His stroke didn't magically reverse and his abilities didn't return. His actual care needs didn't shrink at all, but the care just ended, and now it's on you to do it or pay people out of your pocket. I think that's the gap this new bill in Congress is aimed at, which is called the Medicare at Home Act. Which brings me to a summer afternoon in Missouri 61 years ago. On July 30, 1965, Lyndon Johnson, he didn't sign Medicare in Washington. He flew to Independence, Missouri, to the Truman Library and signed it in front of Harry Truman, who had pushed for national health insurance 20 years earlier and been beaten badly for it. Truman was 81 at the time. Johnson handed him Medicare card number 1. I think it was a beautiful piece of political theater, but look at what was in the box. Medicare was built on the model of working age hospital insurance. Hospitals, doctors, surgeries, acute illness, the kind that you get and then you either recover or you don't. Long-term care for older adults didn't fit in that model, and the people who wrote the bill knew that. Custodial care isn't just a one-off event for older people. It's something that many people need indefinitely. It doesn't end. Ensuring that looks less like insurance and more like a pension. So they just left it out and told themselves it could always be added later. Well, unfortunately, here we are 61 years later. Later is this new bill, but it has 0 co-sponsors and is sitting in committee. So what is this new bill? It's called the Medicare at Home Act. It's in the House, it's H.R. 10020, introduced August 3rd, 2026 by Representative Debbie Dingell of Michigan. In Senate, it's S. 5270, introduced 2 days later by Senator Andy Kim of New Jersey. It amends Title 18 of the Social Security Act, the section that created Medicare. It creates a new benefit under Part B, not Part A, the hospital side, but Part B, the outpatient side. Remember that because it decides who pays. The benefit is up to 20 hours a week of caregiving help with activities of daily living, bathing, dressing, eating, toileting, transferring, and instrumental activities of daily living, which is a technical term for things like meal preparation, light housekeeping, medication reminders, and even shopping. To qualify, a doctor has to certify that you need help with at least 2 of those daily activities, or 2 of the instrumental ones, or 1 of each. There's no asset test, no income test. You don't have to be poor. If you're already getting the same services through Medicare or through Medicaid, you can't double dip. And now the part that matters the most. This benefit is not attached to skill care, and it's not attached to the homebound rule. I think that's a major structural change. Under today's law, getting a caregiving aide at home is just support staff, only covered if you need a nurse or a physical therapist, and typically only temporary. Under this new bill, functional needs alone is the trigger of being able to get caregiving help. So your father who plateaued after a stroke would still get help, because the question stops being, is he improving, and becomes, can he bathe himself? I think that's genuinely new and a huge step in the right direction. Now, how much is 20 hours a week? Well, it's about 3 hours a day. It's not around-the-clock care. It's not a nursing home substitute for somebody living with advanced dementia who wanders at night. Full-time home care typically runs about 40 to 40 hours a week, so loved ones can actually go to work. This covers a little less than half of that. But I think it's a big step in the right direction. Now, who pays for it? You do. Specifically, the bill says that the Secretary of Health and Human Services shall adjust the monthly Medicare Part B premium to reflect the added costs. Part B is the piece that most people on Medicare already pay for every month. It comes out of your Social Security check. About a quarter of Part B is funded by those premiums. The rest comes from general tax revenue. So a new Part B benefit means two things. Premiums go up for everyone with Part B, and the federal deficit absorbs the rest. I want to be precise here because this gets garbled constantly. This bill does not touch the Medicare Hospital Trust Fund, the one that you sometimes hear in the news is running short. That's Part A. This is Part B, which is refilled every year by law. The fiscal concern here is that everyone's premiums go up, including people who never use the benefit. How much? Nobody knows. There's no Congressional Budget Office score. The bill doesn't even ask for one up front. It asks the CMS's chief actuary to estimate the premium impact within 180 days after it becomes law. I think that's totally backwards. What we do have is outside modeling. Analysts at the Brookings Institute have estimated a benefit of roughly this shape at about $40 billion a year, around a 4% increase in Medicare spending, with roughly 15 million Medicare beneficiaries potentially eligible based on the Kaiser Family Foundation analysis of federal survey data. So supporters of this make a real argument on the other side of the ledger. 3 hours a day of help is associated with fewer falls, better medication adherence, fewer emergency room visits, and delayed nursing home placement. And nursing homes cost, Medicaid and Medicare, $100,000 a year per resident. So some of the cost comes back if Medicare can help people avoid nursing homes and stay safely at home. There's one more thing that critics raise, and it has a name, the woodwork effect. Right now, millions of families provide this care for free. If you offer to pay for it, people will suddenly come out of the woodwork. I don't think that's fraud. It's real unmet needs finally showing up. But people worry that it means real usage may far exceed the projections. That's not a hypothetical worry. It's happened before. Which brings me to something almost nobody knows about, in terms of how we got here. Before Social Security, if you were old and broke in America, you went to the poorhouse, county almshouses. They were notorious, cold, crowded, and genuinely feared. Getting rid of them was one of the biggest emotional engines behind the Social Security Act of 1935. Justice Benjamin Cardozo, writing about the law, described its hope as saving men and women from the rigors of the poorhouse. So Congress wrote in a rule, old age assistance money could not be paid to anyone living in a public institution. Cut off the funding and the poorhouses die. They died, but read that rule again, public institution. Nothing stopped payment to someone living in a private one. And so people opened private homes for the elderly, boarding houses, converted mansions, nursing homes. A law that was written to close the institutions accidentally seeded a private industry, one that Medicaid would eventually pour billions of dollars into every year. Congress reversed the public facility ban in 1950, but by then the shape of American long-term care was set. Private facilities publicly paid for with taxpayer dollars, with families stuck in the middle. That's why Medicaid, a program that was originally built for poverty, became the country's biggest long-term care insurance plan. And it's why, to get it, middle-class families do what they call spend down. You liquidate your loved one's savings, retirement accounts, sometimes home equity, until you're down to around $2,000 in countable assets. There's a 5-year look back on anything you gave away. And even when you qualify for home-based care, roughly 700,000 people are still on waiting lists, averaging about 3 years. Medicaid law has to cover a nursing home, but home care is optional. I think that's called institutional bias, and it's still on the books 27 years after the Supreme Court's Olmstead decision held that keeping people in institutions unnecessarily is discrimination. Now, let me give you the strongest case against this new bill, just so we can fairly cover both sides. Brian Blaze of the Paragon Health Institute argues that any new Medicare benefit should be net zero to the federal budget, given the program's budget trajectory is already shaky. Michael Cannon of the Cato Institute has called a comparable proposal fiscally reckless, arguing that Congress has a spending problem rather than a revenue problem. Mark Warshawski of the American Enterprise Institute warned specifically about the financing design, asking seniors to pay higher Medicare premiums for a benefit that most people won't actually use in a given year. And on the supporting side, Nicole Jorwich of Caring Across Generations, Natalie Keene of Justice and Aging, Katie Smith-Sloan of Leading Age, and Connie Garner of Allies for Independence, as well as Leslie Frayne of SEIU, whose argument is one that people underrate. There is no benefit without a workforce. Home care aides have some of the highest turnover of any job in America. Frayne's point is that a stable federal payment source is what turns those jobs into jobs that people can keep. I think the critics' sharpest argument here isn't ideological, but historical. In 2010, tucked inside the Affordable Care Act was a long-term care program called the CLASS Act, Senator Ted Kennedy's life's work, passed months before he died. Voluntary, you'd pay in and later draw a cash benefit. Sounds reasonable, right? In April 2010, before the law was even signed, Medicare's own chief actuary, Richard Foster, warned of a serious risk of adverse selection, meaning that if it's voluntary, mostly sick people will sign up, costs will rise, premiums will rise, healthy people will leave, costs will rise again, and it turns into a death spiral. In October 2011, HHS Secretary Kathleen Sebelius announced she couldn't find a viable path forward, so by January 2013, Congress repealed it. This new Medicare at Home Act is designed to dodge that specific bullet. It's not voluntary, it's mandatorily built into Part B, which nearly everyone on Medicare has. Universal enrollment is the only cure for this adverse selection. But there's a second graveyard here, and this one's about politics. Back in 1988, Congress passed the Medicare Catastrophic Coverage Act. Real benefits, a cap on hospital costs, the first outpatient drug coverage. It was signed by President Ronald Reagan and funded by a surcharge on higher income seniors. Well, unfortunately, seniors revolted. They felt that they were being asked to pay for a benefit that they hadn't asked for. On August 17, 1989, Dan Rostenkowski, who's the chairman of the House Ways and Means Committee, one of the most powerful men in Washington, left a meeting in his own Chicago district and was surrounded by protesters, who were mostly older women. They chased him. He got into his car. A woman named Liana Kozian ended up on the hood. The photographs ran nationwide. By December, Congress had repealed that law. It remains the only major entitlement expansion repealed almost immediately after being enacted. So now, look at this new Medicare at Home Act's funding line again. Adjust the Part B premium. They're making the seniors pay for it. I think the ghost of 1989 is in that. And anyone who tells you the fiscal debate here is manufactured hasn't really read and thought through the history. So what do I think are the honest odds here? This bill so far has 0 co-sponsors, no score, 7 pages, and sits in committee. Predecessors like the Build Back Better bill's $150 billion Home Care Act provision, the WISH Act, the Better Care, Better Jobs Act, all have died. 2 things to watch here, a CBO score and bipartisan co-sponsors in the double digits. Until those appear, I think this is just agenda-setting legislation. Important but not imminent. It could just be politicians trying to look like they're doing something before the midterm elections. Which is exactly why the next 3 minutes here matter more than everything. Because there is a benefit you may already be owed, and you may be getting denied. In January 2013, a federal court in Vermont approved a settlement in a case called Jimmo versus Sebelius. For decades, Medicare contractors had applied something called the improvement standard, the idea that if a patient wasn't getting better, skilled care wasn't covered. That standard was never the law, it was just a habit. The 2013 settlement ended it. Coverage of skilled care depends on whether skilled care is needed, not on whether the patient is expected to improve. Medicare covers skilled care to maintain a person's condition or to slow decline. Someone with Parkinson's, ALS, MS, or advanced dementia can qualify for skilled therapy precisely because they're not going to get better. CMS rewrote its own manuals in December 2013 to even say so. Here's the problem. A survey by the Center for Medicare Advocacy found that nearly 40% of responding providers and advocates had never heard of the settlement, and over 70% didn't know about the education campaign CMS was required to run. So here is a valuable sentence you can use. Under the Jimmo versus Sebelius settlement, Medicare covers skilled care to maintain a condition or to slow decline. Improvement is not required. Please document your denial in writing. Just say those phrases to the agency, say it to the discharge planner, or put it in an appeal. Ask for the denial in writing. I think those things alone can change the conversation because it can turn an informal brush off into a documented decision, and it can start an appeal clock that you can actually use. The Center for Medicare Advocacy publishes free self-help packets on this, so please look into that. That single paragraph may be worth more to your family this month than anything that Congress introduces that may or may not pass. Here's a few more resources that exist today that I think too few families use. The Elder Care Locator, 1-800-677-1116, federally funded. It connects you to your local area agency on aging, which administers the National Family Caregiver Support Program, including things like respite, counseling, training, free. You can also dial 211. Your SHIP, that's SHIP, State Health Insurance Assistance Program, free trained unbiased Medicare counseling in every state. Consumer-directed Medicaid. In many states, a family member can actually be paid to provide care. Not everywhere and not for everyone, but please look into it because it could help you. For veterans, if you or your loved one served, look into aide and assistance and the VA's Caregiver Support Program. These are great benefits and enormously underclaimed. For dementia specifically, CMS runs the GUIDE model, care navigation, a 24/7 helpline, and up to $2,500 a year in respite care for caregivers at no cost to the beneficiary through roughly 300-something participating organizations. Verify that they're still operating and find a participant through CMS. And PACE for people 55 and older who need nursing home level care but can live safely at home. Operates in about 33 states with around 90,000 participants. One note of caution. If you're on Medicare Advantage and saw an ad about in-home help, those benefits are real but often thin. CMS's own rules now require plans to send a mid-year notice of unused benefits, precisely because plans market them heavily at enrollment and often don't follow up. So call your plan and ask what you're actually entitled to in writing. And one number to remember when anyone tells you that all of this is too expensive. Median cost of a home health aide in 2024, $77,000, $792. It's almost $80,000 a year. Nursing home, private room, $127,000. Meanwhile, 59 million Americans provide care for free. 50 billion hours, worth about $1 trillion a year, according to AARP. Millions of us are caregivers, and we're paying the price with our money and our time to care for our loved ones. It's being paid in lost wages, lost promotions at work, lost Social Security credits, and critically lost sleep. I think the only question is whether the work of us caregivers stays invisible any longer. So will this Medicare at Home Act pass? It could, but it'll likely need some revisions. I think there's a lot of pressure from caregivers across the country who need more support. Go back to Missouri in July of 1965. Harry Truman had fought for national health insurance in 1945 and lost so badly the idea was considered dead for a generation. 20 years later, he was sitting in a room watching then President Johnson sign it into law and hand him the first card. I think long-term care for older adults in America has been sitting outside that room for 61 years, waiting to be let in. If somebody in your life is doing this work right now, the bathing, the dressing, the getting up at 3 a.m., doing that all unpaid and unseen, please send them this video. Tell them about that Jimmo decision. Give them the elder care information and the numbers. 93% of Americans believe Medicare covers care at home. Make sure that the person you love isn't finding out the hard way in a hospital hallway. I'm Neil K. Shah. Let's take care of each other, and I'll see you in the next one. Thank you.